Good afternoon. Welcome to today's Wisconsin Health News virtual briefing on the state of oral health in Wisconsin. My name is Tim Stum. I'm the editor of Wisconsin Health News. Thanks to all of you for tuning in. We have a really great panel with us today to talk about this important topic. I am thrilled to introduce Dr. Tom Reid, president of the Wisconsin Dental Association, Layla Merrifield, president of the Wisconsin Technical College System, Matt Crespin, Executive Director for Children's Health Alliance of Wisconsin, and Dr. Pat Remington, Professor Emeritus for the UW School of Medicine and Public Health. Thank you all for sharing some of your valuable time with us today. Before we get started, I want to make sure we thank our very generous sponsors of the Wisconsin Health News virtual series. Healthcare leaders from across the state sign up to watch these virtual events. They would not be possible without the generous support of our sponsors. So a huge thank you to Aurora Healthcare, AARP Wisconsin, Anthem Blue Cross and Blue Shield of Wisconsin, Delta Dental of Wisconsin, Amplify Health, and Quartz. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial, which you can do on our website at wisconsinhealthnews.com. And an extra thanks today to AARP Wisconsin, today's featured sponsor. We are very grateful for all of their very generous and continued support. Here to say a few words is Jim Flaherty, Communications Director for AARP Wisconsin.
Thanks, Tim, and good afternoon. I guess it is afternoon, everyone. As Tim said, I'm Jim Flaherty. I'm Communications Director for AARP Wisconsin. We're based in Madison, but we're all over the state. And we're thrilled to be among the Wisconsin Health News sponsors, and I look forward to today's discussion. I just want to give you a little background. I want to leave as much time as possible for the panelists, but a little bit of background about AARP. We've got about 800,000 members in Wisconsin and about 39 million members across the country. The state offices, every single state has a state office of AARP, and we work on helping all of our residents age with dignity and purpose in a variety of ways. We want to help them live their best lives going forward, whether they're still working, transitioning into retirement, or in retirement. We are a nonpartisan organization, but we do advocate for legislation at both the federal and state level that we believe will benefit all Wisconsinites as they age. And these can be issues such as supporting family caregivers, lowering drug costs, lowering healthcare costs, expanding access to high-speed internet, helping workers save for retirement, those kind of issues. And we also work with local leaders across the state to help them develop plans to make their communities more livable for all ages. And this means focusing on issues such as affordable housing options, expanding public transportation, pedestrian and bike safety, and multi-use parks and open spaces. So, we want people who live in communities to be able to live there their entire lives, and communities need to adapt to that. We also have volunteers who help Wisconsinites avoid becoming victims of scams and fraud. We have folks that help folks fill out their tax returns at no cost. The AARP Tax Aid Program, AARP Driver Safety helps folks become better drivers on the roadways. So lots and lots of different arms of AARP. Like you, we understand how critically important it is for Wisconsinites to have access to quality, affordable health care at all stages of their life, regardless of their income level. And that's why we're working with Congress right now to assure that folks don't lose the benefits they've earned throughout a lifetime of hard work and deserve to be there when they retire. We look forward to working with our volunteers, our members, and other organizations like yourself to make sure that programs like Social Security, Medicare, Medicaid remain strong and sustainable for all generations. We know there's turbulent times in Washington right now, and we're hearing from older Americans who are actually very confused and concerned and upset about the future of their benefits, which is why we're here. We will always have their backs and make sure that AARP does everything in our power to help them keep their earned benefits and don't fall through the cracks of the partisan politics. So thank you very much. I look forward to sitting back and learning more during today's discussion, and I'll turn it back to Tim.
Great, thank you. Thank you, Jim. And thanks again to AARP for all of the generous and continued support. And thanks again to our panelists for sharing some of their valuable time with us today. as the water fluoridation debate gains traction in Wisconsin concerning health and dental experts. Access to care remains an issue for many Badger State residents, especially those with low incomes and special needs. Wisconsin officials have taken a number of steps to boost access. They approved a path for dental therapists, pumped money into the technical colleges, and funded a residency program at the Marquette School of Dentistry. So what impact are these changes having on access, and what more needs to be done? We have an expert panel with us today to discuss this and fluoride and what's next for oral health in Wisconsin. So a lot to talk about. Dr. Reid, let's start with you. Just to kind of set the stage, what briefly are the top issues facing oral health in Wisconsin right now?
Yeah, absolutely, Tim. First of all, thanks for having me today. Truly appreciate it. As we look across the state, there are different topics that certainly pop up. First and foremost, obviously, fluoride. We keep hearing more and more about community water fluoridation, and communities are debating whether or not to continue to have fluoride in their water. We at the WDA definitely think that's incredibly valuable. The American Dental Association also thinks that, as do most health groups in general. So that's one of the top items. Additionally, we keep looking to Marquette University School of Dentistry and all of the good work they're doing, some of the programs they want to expand. Obviously, you hit upon their GPR. We're really quite excited about that, and I think that's going to be a huge benefit, not only for Marquette and the citizens there in Milwaukee, but also the entire state. And then I think you also mentioned access to care issues. You know, those are always first and foremost in our mind. Anytime we can take down some of the barriers and make it easier for folks to seek out proper dental care and oral health care, we're there as an ally, hoping to achieve that common goal.
Great, thank you. Matt, how would you answer that? What do you see as the top oral health issues in Wisconsin right now?
I mean, I'd certainly agree that fluoridation seems to be an ongoing debate across the state. We see small communities, large communities taking up this issue. And if I could, I would like to provide just a little bit of context on why that's happening. I think, we've heard fluoride come up from the current federal administration. And more recently, we've heard advocates that want to remove fluoride from the water refer to a couple kind of key studies. One, not really a study, but a lawsuit that was settled with the EPA that primarily used data that was published by the National Toxicology Program, or the NTP. And I think what's really important from a context standpoint is that if you read the NTP report, which was primarily used in this lawsuit that was against the EPA, and it's used oftentimes in communities, it's really important that you read the very first page of the NTP report, because in that report, it specifically says that the NTP report was designed to evaluate total fluoride exposure from all sources and was not designed to evaluate health effects of fluoridated drinking water alone. And in bold, it then goes on to say, it's important to note that there were insufficient data to determine if low fluoride levels of 0.7 milligrams per liter, which is what we use in the United States, has a negative effect on children's IQ. And this has gotten headwinds with the publication that came out in the Journal of the American Medical Association. A lot of media picked this up. What's interesting about that is 52 of the studies that were included in that 74 study systematic review had a high risk of bias. What unfortunately wasn't picked up by the media was the response by Dr. Steve Levy, who is a dentist in Illinois, or in Iowa, excuse me. And his response talks more in depth about why this study should be read with caution or interpreted with caution. And another study that recently came out just shortly after that was done in Australia, where it actually showed an inverse correlation between IQ and fluoride exposure. And this was done at the very individualized level. And then lastly, as it relates to fluoride, the thing that I think is really important for us to keep in mind is that Calgary removed fluoride about 10 years ago. And after about 5 years, there started to be some red flags that were raised. And after 10 years, they've now reintroduced fluoride into their water because of the amount of disease that they've seen. And just one piece that I'll share with you that was publicized by them is that the number of children that received IV antibiotics for dental infections in Alberta Children's Hospital increased by 700% between 2011 and 2018. And the majority of these patients were under 5 years old. So we know that fluoride is effective. We know that the studies that are used by opponents are often filled with bias and don't really evaluate fluoride at the levels that we use in the United States. And we know that it doesn't have an impact on IQ, and we know that it prevents disease. So fluoride, first and foremost, we need to continue to use this very proven public health practice in Wisconsin. Access to providers continues to be an issue, in particular for Medicaid patients or patients that are uninsured or underinsured. There's just far and few between, unfortunately, dental practices that will accept patients with Medicaid. We've made a lot of headway in our school-based sealant program that we partner with the Department of Health Services and Delta Dental of Wisconsin on. See about 80,000 kids across the state. But unfortunately, about 40% of those kids need follow-up care. And so finding that follow-up care can be a challenge when those programs are not provided by an FQHC that have a direct referral source or a free and community clinic that they might work with. So that continues to be an ongoing issue of early intervention, prevention, and then follow-up when needed.
Great. Thank you, Matt. And we're going to dive into pretty much all that, a little later in the program. Layla, want to ask you kind of that same question, in terms of top issues. I understand the tech colleges have an advisory board of employers that you meet with regularly to help determine your program offerings. What are your employer partners saying about oral health, and how is that determining, what type of programs you're offering at the tech colleges in Wisconsin?
Yeah, absolutely. So every program at the local level has an advisory board of employers, and we meet with them twice a year, and try to really get boots on the ground, sort of ground level information about what employers are seeing and the struggles that they're facing. We all obviously use Bureau of Labor Statistics and Lightcast and all those sorts of things, but we find that it's good to trust but verify and make sure that that regionally that those sorts of data points are the same or make sense to our employers. But certainly, it's cyclical, like everything within industry and the economy, and so we try to throttle down and throttle up our programming in our cohorts according to what makes the most sense for local economies and local employers.
Great. And what are they saying? What are they saying about oral health?
Well, oral health is in one of those periods where we have to throttle up, right? This is so we've worked pretty closely with the Wisconsin Dental Association over the past couple of years. They put together a task force to take a look at this issue, at the workforce issues that they were seeing, so we've gotten the message, and of course that was reflected in the last state budget. We saw an investment in the technical college system, specifically around increasing cohort sizes for some of our dental workforce that we educate at the technical college level. So that looks like EFTA, that looks like dental assisting, that looks like dental hygiene, and then a new program that we're hoping to get going in the next year would be dental therapy. So that's taken an investment. We're very aware in the technical college system that we don't do anything alone. Everything takes partnership, including sort of big picture policy concerns like the workforce shortage that we're seeing in dental.
Great. Pat, what would you add to that? What would you say are the top oral health issues in Wisconsin right now?
Well, I think it's, there's a difference between what the data would say, what the burden of disease is in the community and where all the energy is. Clearly, there's a dissociation. I think access to care, particularly with people with limited resources, has always been an issue. When I was at the state health department for a decade and oversaw the dental oral health program, and Greg Nitsch, a colleague of mine in Marshfield, has always talked about the focus on access, particularly for people either without insurance or with Medicaid. So, but all the noise, all the energy seems to be focused on community water supply and concerns about fluoride. So I think you have to address both. You have to sort of keep at, as Matt and Tom said, keep at the fundamental issue of providing high quality access to dental services to all, regardless of their economic situation. But we also have to address the public concern about fluoride and, do so in a thoughtful and respectful way. I completely agree with Matt. When I got sort of this became a hot button issue, I read the NTP report. Interestingly, by the way, first authored by a former graduate student of mine, Kyla Taylor, went to our program. She got her PhD at UW. So that's a complicated report. I read it again this morning. I read the letters to the editor, Dr. Levy and others. It's incredibly complicated. And I think we should, have scientists debating this and coming up with sort of an assessment. What is the state of the science right now? And then the public debate can be informed about what we know, what we don't know, and then what's best for people in every community.
Thank you, Pat. So let's talk a little bit about fluoride. As is mentioned, this is the oral health issue that is in all the headlines right now. I've seen a number of panelists quoted and a number of media stories over the last couple of months. President Donald Trump's Department of Health and Human Services Secretary Robert F. Kennedy is a skeptic. He has said he supports removing fluoride from public water. But this is an issue certainly that predates RFK Jr., as nearly 80 Wisconsin communities have moved to discontinue fluoride. About 40% of those 80 communities have done so since 2000, including DeForest outside Madison, which voted in February of this year to remove fluoride from its water. Nationally, Utah is set to become the first state to ban fluoride, and other states, including Florida, are having some serious conversations about doing the same. Matt, I know this is an issue that you follow closely. You have followed closely. I've read your Children's Health Alliance newsletter update for years, talking about the different communities that have done this. I mean, what do you think? What do you think, as someone who follows this closely? What do you think is driving some of these communities to make this decision to remove fluoride from their drinking water?
I mean, I think often it's just a lack of understanding of the science. I mean, I think Dr. Remington hit it on the head that we need to have scientists having these discussions and not, vocal advocates of removal of fluoridation that don't have the scientific backing and scientific knowledge to have this understanding. And unfortunately, I think local decision makers are often put in a position where they are either feeling fear of maybe something that they're doing in their community that could be bad because they themselves might not understand the science. And I think sometimes the thought is made of, there's many other sources of fluoride where we can get that from, whether it be toothpaste or topical fluoride applications in our dental office. But we know that there are many people across our state and across the country that simply don't have access to some of those basic needs that, whether it's access to a dental office to get topical fluoride or treatments when the fluoride, there's a lack of fluoride access or lack of dental access and restorative care is needed. It's really driven oftentimes by a handful of very vocal, outspoken advocates that get in the ears of local decision makers. And unfortunately, what we've seen happen in Wisconsin, and it actually happened to me personally, is we see a level of intimidation at times where there have been complaints filed against dental providers' licenses that come to city council meetings that support fluoridation. I myself had to go through that and respond to a complaint to the Wisconsin Dentistry Examining Board. And again, as Dr. Remington said, this is not where we need to be spending our energy. And unfortunately, it's a lot of noise that takes us away from some of the other important things we should be doing.
Matt, do you see this noise continuing? I mean, do you expect, kind of given all this energy that's being focused on this right now, that we're going to see even more Wisconsin communities kind of follow DeForest's recent lead in the coming year or two?
Unfortunately, I do. I mean, in the 20 years I've been doing this work, I've never seen it amplified to the level that it is now. I mean, I would say on any given year, we might deal with a handful of rollback attempts. And we're dealing sometimes with a handful of rollback attempts a month in the last 6 months. It's been pretty busy.
Pat, and Matt addressed this a little bit just now, but can you talk about why? I mean, why is this such a big deal? When Grand Rapids became the first city to add fluoride to its water supply in 1945, I mean, fluoride wasn't as readily available as it is now. I mean, now you can get the fluoride treatment from your dentist. You can get, mouthwash at Walgreens. Why do we still need to put fluoride in our water?
Well, I think the key answer is that it's better for the health of the public. There's good evidence that shows that communities that have fluoridated water have fewer dental caries and loss of teeth. I think one of the reasons this comes up is that people forget the burden in the population about things that happened a long time ago. I remember when I was in medical school and during my internship, more than half of my patients over 65 were edentulous. I talk about that word today. Not many people even know what that word means. It means you don't have any teeth in your mouth. That was common. None of my 4 grandparents had teeth. They lost their teeth because they had dental caries, and again, maybe a bothersome tooth was removed. But that's very uncommon today. So we have improved, I think it's not just fluoridated water, but better oral health care. We've improved that. And people forget those days when, you turned on the television and the ads you saw were about denture cream and Polydent and ways to handle your dentures. And people are a lot better off today having their own teeth as they get older. So we've forgotten that. So I've seen a claim by an advocate that there's no proof that fluoride improves oral health. And the reason they said that is there's been no randomized, double-blind, placebo-controlled trial. And yet the next word that comes out of their mouth is that, but it harms children's IQ. And if we hold that same standard to the evidence about harms, there's been no randomized controlled trial. And as Matt said, even the authors of this paper cautioned the interpretation about these studies. By the way, none of which has been done in the United States, which I find interesting. Most of these are studies come from China. Most of them are poor quality. So I think that's a background issue. And then the final thing I think is, why do we see concern? And one reason is fluoride is a metal or similar compounds, and we're concerned about lead, we're concerned about heavy metals, and so that may be the root cause of this concern. Lead is a good example of something that has no health benefits, and society was really asleep at the wheel when lead was put in paints and gasoline, and we've been dealing with that harm forever. And I think we have to realize that there is potential risk at high exposures of fluoride, and acknowledge that potential risk, and then talk about what we do to reduce that risk. The fact that from 2015 to today, the recommended level is in fact lower. We still get the health benefits, but with lower risk of complications like fluorosis and other things.
But given just the, significant increase in availability of fluoride through other means now than there used to be, doesn't it make sense to give some of these communities, a choice on whether or not they want to put this in their water?
Well, obviously they have the choice. That's the political process. So I wouldn't recommend ever taking that away and dictating, standards from a national or even a state level. I think local control is important, but local control with proper information. And I do think that you could imagine a community that is not fluoridated. In fact, Europe, a few countries in Europe have community water supply with fluoridation. So you can do that. Europe has universal health care. Everyone is covered. And so that's not the case in the US. So we have to have systems like community water supply that address this issue of equity, that if we don't have universal health care, and not everybody is provided with oral health care, then how can we cover the entire population and be equitable? And community water supply fluoridation is one approach. If you remove it, then I think it's incumbent upon that community, the DeForests across Wisconsin, to assure that everybody has good access to oral care, all of the topical sealants and all of the things that need to be done when you don't have community water supply. Like many people in the state that don't have community water supply, but then unfortunately they don't have access to the things that are needed to prevent dental caries. And to me, that's a preventable public health problem.
Thank you. Dr. Reid, what do you think?
Yeah.
Yep. Is there Dr. Reid, I mean, is there enough other ways now, including visiting dentists to get fluoride? I mean, do you think this is something that's still needed in our drinking water?
I'm going to piggyback on a lot of those comments that were just made. First of all, in respect to topical application of fluoride, it is just that. It is topical application. So when we're actually consuming the element of fluorine or fluoride, the compound of fluoride, it acts systemically. What we see that in conjunction not only with that topical application, but also that systemic consumption of community water with proper fluoride levels in it, we see about a 25% reduction in carious issues of cavities. So that's one thing. So I heard one of my colleagues describe it that fluoride in toothpaste and fluoride that you can get at my office, that's kind of like a seatbelt, right? It's one really great way of staying safe in the car. But then having community water fluoridation is like having the airbag. So you're getting the best of both worlds. You're really staying safe at both ends of the spectrum there. So that's one thing I would say. I would agree with Pat. I would say communities should certainly have the say as to whether or not they want to keep fluoride in their water. Of interest, Ladysmith is actually on April 1st taking it to referendum. So the citizens in Ladysmith, Wisconsin will be able to vote directly on a non-binding referendum to advise their community water board whether or not they want to maintain the standard of keeping fluoride in the water. So I think that's rather interesting. Something Pat triggered in my mind as well, as we look and we go back to elementary school and we look at the periodic chart, right? So on that far right-hand column are the noble gases. We have argon, helium, neon. It's that next column over, that's where fluorine resides. Those are the halogens. And it goes fluorine, chlorine, bromine, iodine, right in a row. And each one of those elements we use in water to one degree or another. Fluorine, obviously, to help with cavities. Chlorine, to help keep water free of bacteria. Bromine, a lot of people will put it in their spas or their pools. And iodine, we put that in salt. So all of those elements in that halogen column serve a really useful role if they are dosed at the appropriate levels. I can't imagine if a community were to look at their water supply and say, boy, I don't want chlorine in my water. We would all think that was absolutely crazy because we would see a huge spike in E. coli infections for people consuming water without chlorine in it. So that's certainly something that, Pat, you brought up that I find interesting. I hope I didn't bore everyone with some elementary chemistry there.
Dr. Reid, what do you think would be the impact on oral health outcomes if more Wisconsin communities continue to vote to remove fluoride from their drinking water?
Yeah, it's not like we haven't dealt with this in the past. As Matt mentioned, Calgary, Canada took fluoride out of their water in 2011, I believe, and saw that huge increase in caries rates and in cavities in kids and adults and geriatrics and just across the spectrum. We would see a spike in cavities. It is not coincidental that the day that Robert F. Kennedy was nominated as HHS secretary, stocks of dental stocks in the stock market went up between 8 and 12%. And that was just based on his nomination. So people who actually have skin in the game and have money in the market know that people like me are probably going to be doing between at least 8 and 12% more work and treating more cavities. So, you know, I think it would be disastrous, is what I think, if we were to see more communities go the route of deforest. Of note in deforest, the majority of their citizens came out in support of keeping fluoride in the water during those meetings. So I somewhat respect Ladysmith that they're actually taking it to referendum and actually letting their citizens have a voice. When citizens actually spoke up in deforest and in most communities, a lot of times their leaders don't listen to them, and they make a decision based on erroneous information, in my opinion.
So a reason I'm hearing, is for continuing fluoridation in public drinking supplies, is access. Dental access isn't something that everyone in the state has. Matt, can you just expound on that a little bit? I mean, what would you say right now are some of the major barriers to dental access in Wisconsin?
Yeah, I mean, I think the fluoride issue is connected to access, but I mean, I will tell you, I have a 10-year-old son and he has access to dental care, and it's important to me that he has access to fluoridated water because I know that it's beneficial. And I think one key point that is often left out of this discussion is that fluoride exists in all water sources naturally. So you cannot add the fluoride, and if the argument is that it's lowering our IQs or causing any of these other things that opponents are saying it is, unless a community removes the fluoride, there's still going to be fluoride there, just not at the level that we know improves oral health. So that's a really key aspect to this. Is deforest is voted to no longer add fluoride, but there will still be fluoride in their water, just not at a level that protects their teeth at the levels that we know. In regards to access, I mean, I think, there has been a number of things that have happened in our state over the course of the past 5 to 10 years that I think are aimed at improving access, whether it be increased Medicaid reimbursement rates, whether it be the expansion and bolstering of many of our federally qualified health centers and free clinics that are providing care to patients and creating more access points for them. Whether it's the now passed and implemented dental therapist legislation, where we now have 3 licensed dental therapists in our state. We have a dental therapy program that will be launching at NTC coming up soon. And in fact, at least one of, I think 2 of those dental therapists are actually already practicing in the state, which is really great. So there are things that are happening, but these are all things that move the needle slowly. There's no one switch that's going to tomorrow fix the access issue, whether it be Medicaid reimbursement or dental therapy or even fluoride. It would take a long time for us to see the impacts of that. So I think we have to continue on this course of ensuring that we're creating access points, that we are maximizing our workforce and having people practice at the top of their license in which they're educated and licensed to do, and continue to find new and innovative ways of reaching patients. And one in particular that we are working on is integrating dental hygienists into medical care teams. So we have about 13 health centers and health systems across the state that have taken a new and innovative approach of hiring a dental hygienist that works with their primary care medical team and sees kids and even pregnant women in some cases when they come in for well child visits. So they're seeing kids as early as 6 months of age. They're providing education to mom, dad, grandma, grandpa, whoever it is that's bringing them in. And we're really getting at that early intervention to prevent disease. So we have to continue to look at new ways to solve this problem. There's a real movement in the oral health space around minimally invasive care that is really focused on treating things early in a minimally invasive way that's not as traumatic to potentially the child. And I think those are ways that dental offices can increase access. They can see more patients if they're not having to do crown after crown after crown. If they're intervening much earlier in a more minimally invasive way, there's many more opportunities we could do there.
Thank you. Layla, could you talk about the steps that some of the steps that the state's tech colleges are taking to boost the oral health workforce, and what impact this could have on boosting access to dental care.
Sure. Yeah, so we did receive a $20 million grant in the last state budget specifically to bolster the talent pipeline that's sending folks into the dental professions, again at the level that we teach. So that 20 million is one-time funding, and it's really about expanding labs and installing chairs and operatories so that we can produce more graduates eventually. Those things are still being built out in most cases. And we'll start to see larger cohort sizes again for all of those levels of certification and license.
And can you, sorry, Layla, to interrupt, but can you just kind of expand on that a little bit more? I mean, this $20 million is impacting almost every tech college in the state. What are kind of some of the things that this money is being used for?
Yeah, so it's again, it's 14 out of the 16 technical colleges that are participating in this grant, and that will look like in at least two colleges. That means a brand new dental hygiene program that will be able to be offered where there was none previously. In most cases, it means larger cohorts in those programs. So hygiene, dental assisting, and you're going to soon see statewide access to EFTA, so expanded function dental auxiliaries. Soon that will be a statewide program. I think we had one or two programs prior to this grant. So in practical terms, that means another 250 enrollments every year across the state will be in that pipeline and coming to dental offices soon within a year or two. Again, the dental therapy program was mentioned. We are still working through CODA accreditation for that particular program, but it's no coincidence that program will be offered at North Central Technical College. It's because NTC is surrounded by dental workforce deserts, basically, because the Northwoods are so severely underserved when it comes to dental care. That's why it's located in Wausau. That's very intentional on the part of lawmakers and WDA and our other partners who made that program possible. So again, it's because we have real shortages in our rural areas. It's not unique to dental, I'll say. This is going to be an ongoing quality of life issue for Wisconsin as our demographics change, as folks move, and as our population ages in the Northwoods in particular. But it is a serious one for quality of life and sort of medical access, dental access. It's a huge issue that was identified. Of course, there are tons of folks in those rural areas who depend on Medicaid in order to access their health care. So again, to tie that in, that is an issue. And we try to serve those needs as they come. We certainly, most of our programs are going to be open to Medicaid patients, are going to be open to the public to come in and receive care in those clinics on our campuses, because we realize that access is an issue. But again, it's most dentists are quite busy in their own practices, and so identifying faculty and bringing those folks onto campus in order to supervise and run these programs is another challenge that we're dealing with all over the state.
And so this dental therapy program, as was mentioned, this will be the first of its kind in the state of Wisconsin. What is, it sounds like you're still kind of, getting over all the last hurdles, but what is kind of the expected, launch date for this? How many students will it enroll? Can you just talk a little bit, about some of those details?
Yeah, so it's moving a little more slowly than we in the tech college system are used to moving. I'll say that. But again, it is a very unique program to do this at the associate degree level. This will be a continuation of a dental hygienist degree, right? So the prerequisite for this program is that you are a dental hygienist, and then we're going to add on another 2 years of education. So it's a unique structure, and so CODA is taking a look at that. We expect, though, a site visit by CODA hopefully in September of 2025, which again is a little bit behind schedule from where we would like to be. And then we hope for full approval by CODA, hopefully by February 2026 at this point. And then we will move on from there. I think we'll probably start mid-semester. We want this program up and running absolutely as soon as possible. And so it is going to be an unusual start date, but we want to get those folks into the pipeline, and the cohort size is planned at roughly 12 to 15. So it is resource intensive to offer dental programs in general for our programs, and again, the dental industry is certainly not alone in their challenges, and so and there's not an industry in this state that we don't touch, right? And so our resources are spread pretty thin and trying to be responsive and meet industry needs throughout the spectrum. Healthcare is a big one. Healthcare is a growing industry here in Wisconsin, and certainly we have access issues there too. But we recognize that dental has to be a priority, and that's why you're seeing this enormous investment in trying to move the needle in the Northwoods in particular.
Great, thank you, Layla. Dr. Reid, can you just briefly talk about some of the steps the Dental Association is taking to bolster access in the state?
Yeah, absolutely. First, I'd like to back up and thank Layla for the fantastic job that the technical colleges are doing, educating our future assistants, our future hygienists, and this new workforce of dental therapists. We worked closely with Senator Mary Felskowski to secure that $20 million that Layla and her institutions could use. And so a big shout out to Senator Felskowski for doing that. I think she recognizes the need and the importance of oral health. Also worked really closely with Speaker Voss and Senate Minority Leader Diane Hasselbein. And so all of those folks have been really, really instrumental in trying to bolster these workforce issues. So thank you again, Layla, for what you and the technical colleges are doing for us. In speaking about rural access issues, whether you have private pay insurance or whether you have Medicaid or Medicare, access to care is a challenge. So one of the other bills that we had passed last session was a rural scholarship program where new graduates graduating from Marquette School of Dentistry can apply for some loan forgiveness for a certain amount of time dedicated to practicing in a rural facility. So that's been a program we've tried to implement for many, many years, and finally got it over the hurdle last session of the legislature. So again, thanks to that group. Additionally, I don't know if you've heard about interstate compacts. Many professions use interstate compacts, whether they're nurses, physicians, whomever. We now have a dental and dental hygienist interstate compact. Wisconsin was the 4th state to sign on to the compact. We're seeing more and more states sign on every year. This will enable providers from anyone within the compact to come into our state and to seamlessly integrate with their license so that they could start practicing in the state of Wisconsin from day one. We think that's really going to be quite helpful. And so that's one thing we also achieved last session. As we look forward, one of the things we're looking at this session is special needs adults. For far too long, access to dental care for special needs adults has been a real challenge. So we're asking the state assembly and the state senate for very specific codes to really bolster the access for those folks who are of special needs. And we think that could be really quite beneficial as well. I don't know if any of you have ever visited our Missions of Mercy program. Every year we have a free and charitable clinic that services thousands of people. It used to be people would line up out the door the night before when we were going to have these events. We no longer quite see that. We think that's a success story, that we're not seeing quite the need that there used to be. This year, it's going to be the end of July in Wausau. So I would certainly invite all of you to come up and participate in that, where you'll see genuinely boots on the ground doing dentistry for people in need. To date, we have donated millions and millions and millions of dollars in free and charitable care to the state of Wisconsin through that Missions of Mercy program.
Thank you. So, there's a lot going on. There's a lot going on to help improve access to dental care in the state. Pat, what do you think more needs to be done? What are, some of the main barriers that remain? Because barriers do remain to access to dental care in Wisconsin.
Well, one thing that I enjoy this conversation, by the way, because it gets me thinking. Matt, you made a comment about sort of the defense strategy that once I was on the Wisconsin Public Radio interview, I was then, the subject of a mass email, all around Wisconsin and around the country. Fortunately, nobody's been knocking on my door, although somebody did say I should get a Ring camera just in case. And that's worrisome, that the passion that people sort of arguing the other side have is so significant that many health professionals are reluctant to speak up, reluctant to come to a meeting. So one thing I think we need to do as health professionals is improve our training in sort of showing up and being credible and really understanding how to be effective as influencers. Because I think if we just sort of sit back, then the folks who do show up, who carry the day and get the votes, will be influencing public policy. So that's, that addresses the fluoride issue. I think it also addresses access issues in that, Tom and Layla, it's things don't happen without funding, and things don't happen without engaging elected officials, whoever's in the majority. So I think those skills are incredibly important to teach our health professionals. Obviously, you want good dentists and doctors and people who are providing care. But I think about our School of Medicine and Public Health. As the Associate Dean of Public Health, I tried to really influence future physicians to understand they have a role to their community as well as to their patients. Because if you simply do patient care, whether it's oral health care or medical care, the broad community is going to maybe do things that aren't good for your patients. And so you need to be proficient in patient care and proficient in advocacy. And so I think however we do that, I'm not sure I have all the answers, because sometimes, despite the best evidence, people who are very vocal carry the day. So that would be my sense, is that continue to influence policymakers so that we have the best policies that can make care more effective and more efficient.
Thank you. Matt, you mentioned earlier that, a main barrier to access that remains for specifically Medicaid patients is that, a lot of them can't find a dentist to care for them. Can you talk a little bit about why you think that is, and maybe what more could be done to boost access to care for Medicaid patients?
I think there's a variety of reasons that lead to that. I think, oftentimes, most dentists across the state are general dentists and don't have a lot of exposure to treating patients with special needs, or even sometimes very young patients. And there's not enough pediatric dentists across the state to see all the pediatric population that exists. So I think, that poses a bit of a challenge in getting resources. We know that Medicaid reimbursement rates in Wisconsin, even after an increase, are still incredibly low. I think we're still in the, below 40th or below in the country in regards to Medicaid reimbursement rates. So there's less incentive for dental offices to see a patient with Medicaid, just because the insurance reimbursement is going to be much less than it would be otherwise. And, I think, kind of going back to one of the topics that I talked a little bit about before in regards to medical dental integration, I think oftentimes when it comes to dental, many times, even whether you have private insurance or not, we don't seek dental care often until there's a problem. So we're less prone to seek preventive care, in particular, as we get older, and we come in when we have an issue, when something hurts. And when something hurts, it's gone well beyond the point of where a simple intervention can exist. And that's why I think the earlier we can intervene in this medical dental integration model that we're trying to push across the country, or across the state, I should say, We're part of a network of 7 states and 1 territory that are working across the country, funded through a grant from HRSA, to really bolster up this work. And it's been reassuring to see many health systems across the state get interested in this. Prevea Pediatrics was the very first standalone health system to launch this model, and their hygienist and soon to be multiple other hygienists that they're working with are seeing patients early on. And so that when they get to be 5, 6 years old, we're not seeing them at Children's Hospital in the operating room. We do something like 900 operating room cases a year. We're preventing that disease way early on, so that when they get to be 7, 8 years old and we see them in the school-based program, they have teeth that can be sealed, not teeth that need to be referred for restoration. So we really have to find new and innovative ways to get to patients in places that they're already accessing. When it comes to medical, we found that about 80,000 kids enrolled in the Medicaid program, ages 0 to 5, were seeing a physician and not seeing a dental provider. So that's a huge window of opportunity to see patients that are already presenting in a medical office. Let them see a dental provider right there.
What do you think, Dr. Reid, what has prevented this integration? I mean, this isn't, obviously unique to Wisconsin, across the country, healthcare and dental care have been separate things. What has, prevented this, further integration and what could be done to help, increase, the worlds of healthcare and dental care?
Yeah, to step back to a comment Matt made, as far as there not being much incentive to see someone who has Medicaid, there's not only not incentive, there's almost disincentive because most of us are small businesses. We all operate in our own smaller offices, typically 1 to 3 dentists in an office. We all have a team that expects a paycheck. We all have lights to keep on and water bills to pay. And at Medicaid rates, we make about 40 to 44 cents on the dollar. Most dental offices have overheads between 60 and 70%. So it's not only that you don't have incentive, you almost have a disincentive. So in all honesty, we really need to incentivize. We need to raise these rates. So at a minimum, dental offices can actually pay their teams a really good wage and keep the lights on and keep servicing all patients. So that's one huge challenge with that Medicaid population.
And so, just, Dr. Reid, just to follow up on that quickly, so Matt mentioned there was in the 21-23 budget,
Yep.
a 40% rate hike in Medicaid for dentists. Was that not enough? Is there a number that would have to be raised past that to help increase access?
Let's do the math on that. So in 2021, and we are incredibly grateful for that huge raise in Medicaid rates from, again, the legislature, and recognize they really went to bat for us. That said, prior to that raise, we were making about 30 cents on the dollar. So now if you add 40% to 30 cents, that takes you up to about 44 cents on the dollar. Again, there's quite that disparity between your overhead, what you need to keep the lights on and the bills paid, and what's actually being provided by Medicaid. I do not at all look disfavorably upon that added Medicaid rate increase that they gave us, and we certainly appreciate that. But it really is not at the level where we need to be. Additionally, prior to that, I don't think Medicaid rates had been raised on the dental side of things for 24 years. So there was a 24-year period where there was no increase up until 2021. So again, that presents some challenges, right? In regards to your initial question about integrating medical care and dental care, again, we typically work in small business environments. We typically have our own in-house software and our own in-house programs and practice management systems, whereas most hospitals and most everyone in medicine operates on Epic, right? That's the big giant computer system that integrates all of our records. I think there would be value in combining those or somehow bridging those systems so that we could further integrate better, as Matt made reference to.
Great. So we have quickly run out of time here. There's a lot more we could talk about, but I want to kind of end by kind of trying to sum this up, and I'm going to ask this final question of each panelist and kind of work our way down the line. And Pat, we'll start with you. What is one thing, if you had to pick one thing, what is one thing that could be done to improve dental access?
Well, I think it's a very big thing, which is to agree that healthcare is a right and not a privilege, and to structure whether it's our payment systems or how we organize medicine and dental care, is to structure it so that it's fair and equitable. And other countries, in fact, every other developed nation in the world has been able to do that, including our Canadian counterparts. I think we need major restructuring of our healthcare system to assure that healthcare is a right and not simply a privilege for those who can afford to pay.
Thank you. Dr. Reid, how would you answer that? What is the most significant thing, or one significant thing that can be done to improve dental access?
Yeah, my gosh, I don't know that I could narrow it down to one. There are a lot of baseball games won on singles and not on home runs. So I think continually coming up to the plate and hitting singles and really trying to use many different solutions and target this problem from many different aspects would really be beneficial. If I were asked specifically for just one, dental students are coming out of dental school with an average debt load of $312,000. $312,000 to get a kid through dental school. If we could somehow address the cost of dental education, that could open up opportunities for new grads to go to rural areas, to see more people on Medicaid, and to really have a choice in where they practice and how they can repay those loans. Or not have those loans possibly. Really addressing those educational dollars could be very, very beneficial if I were to ask to pick just one.
Great, thank you, Dr. Reid. Layla, what would you say? What is one significant thing that can be done to improve access to dental care?
Well, I to sort of build on Tom's point, I think incentives for dental providers to practice in small towns and rural areas in Wisconsin, in particular, this is a very rural state. That has to be part of it. If I can throw in sort of an out of the box idea but still sort of playing on that point, mobile labs are something that we're taking a hard look at. Northwood Tech now has a dental mobile lab in order to, if you can't open up a clinic, if there's just not enough business in one particular small town, if we can at least have access to more mobile labs that can move around and bring dental providers to those patients, at least on a short-term basis, we could potentially serve a lot more folks.
Great, thank you, Matt. We'll give you the final word. What's the most significant thing that can be done to improve access to dental care?
Well, I'm glad I got to go last because Dr. Remington took my number one, which is payment reform. So I don't have to waste that one. And Layla said my next one, which is taking care to patients and mobilizing care. I think broadly, we just have to be more innovative and we have to be able to embrace change more quickly. We've been practicing dentistry in a very similar way for a long time. And we know how to prevent dental disease, and we continue to see lack of access. We continue to see disease rates climb. And so we have to really be creative and, use things like medical dental integration and minimally invasive care and really get to the heart of the issue at an earlier point in the intervention versus waiting till it's at a point where we're having to take a child to an operating room to treat them for dental disease.
Well, thank you, Matt, and thank you all. This has been a great conversation. I really wish we had more time on this one. We'll have to do another one soon. But thank you all. This has been great. Thanks to our generous sponsors for making this possible. We'll be back in person for our next event on April 8th in Madison, where we'll have a newsmaker event with DH Secretary Kirsten Johnson. More information, as always, can be found on our website. thank you all and for tuning in, and have a wonderful day.
Great. Thanks, Tim. Good to
now.
see everybody.